The SELECT trial, addition of semaglutide to reduce the incidence of major cardiovascular events amongst patients with overweight or obesity and pre-existing cardiovascular disease who do not have diabetes. More than half the world's population is projected to have obesity or be overweight by 2035. Elevated BMI is estimated to account for 4 million deaths globally, most of which is cardiovascular. To date, no drug or lifestyle management, including bariatric surgery, has actually shown to reduce cardiovascular events in randomized trials in this population. GLP-1 receptor agonists have been shown in diabetic patients to have a potent effect on glycemic control, but also reduce cardiovascular events in patients with diabetes. Semaglutide is a potent GLP-1 receptor agonist which produces substantial weight loss in patients who are overweight or obese, but it is unknown whether these agents can reduce cardiovascular risk in patients who do not have diabetes. So 17,604 patients were randomized to receive either semaglutide with a target dose of 2.4 milligrams weekly or placebo. Mean duration of exposure to semaglutide or placebo was about 34 weeks. Key inclusion criteria included patients over the age of 45 with a body mass index greater than or equal to 27 kilograms per meter squared, and established cardiovascular disease, either CAD, CVD, or PAD. Exclusion criteria included a history of diabetes, hemoglobin A1C is greater than or equal to 6.5%, being on any glucose-lowering agent, class 4 heart failure, vascular events in the past 30 days. Here are the baseline characteristics. Majority of patients were white male. The median age was 61.6 years. Average body weight was 96 to 97 kilograms, which is about 212 pounds. Average BMI was 33. 71.5% met the BMI criteria for obesity. The mean glycated hemoglobin was 5.8%. Blood pressure was well controlled, as was the LDL. More than 3/4 of the patients had a previous myocardial infarction and 1/4 had chronic heart failure. The use of guideline-based medical therapies for cardiovascular disease appeared to be well balanced between the groups. Most patients were receiving lipid-lowering agents, platelet aggregation inhibitors, beta blockers, ACE inhibitors, or ARBs. Here are the results. Death from myocardial causes, non-fatal MI, non-fatal stroke, occurred in 701 patients in the placebo group and 569 patients in the semaglutide group. This difference began to occur early after initiation of treatment. The hazard ratio was 0.80, a 20% risk reduction, and a p-value less than 0.001 for superiority. The absolute risk reduction was 1.5% over the average follow-up. This magnitude of treatment effect was consistent across all pre-specified subgroups, including sex, body mass index at enrollment, and the presence or absence of prediabetes. The first confirmatory secondary endpoint was death from cardiovascular causes. The hazard ratio for this was 0.85, but this difference did not meet the nominal significant level required to meet superiority. According to the hierarchical strategy, superiority calculations were not performed for the subsequent secondary endpoints. The second confirmatory endpoint was a heart failure composite of a cardiovascular death or heart failure hospitalization. The hazard ratio was 0.82 with an upper limit of the confidence interval at 0.96. The third confirmatory endpoint was death from any cause. Hazard ratio was 0.81 with the upper limit of the confidence interval of 0.93. There were numerous supportive secondary endpoints which were concordant with the primary endpoints. The most reduction was with non-fatal MI and the need for coronary revascularization. Change in body weight in the semaglutide arm was 9.4% reduction compared to placebo, which was a 0.9% reduction. There was also a significant reduction in waist circumference of 7.6 centimeters, which is 3 inches, in the semaglutide arm. There was no significant difference in terms of serious adverse events. In fact, there were fewer serious adverse events in the semaglutide group. Adverse events leading to permanent discontinuation occurred in 16.6% in the semaglutide patients and 8.2% in the placebo group. Most of this was driven by gastrointestinal effects. In conclusion, patients with overweight and obesity with pre-existing cardiovascular disease without diabetes had a 20% reduction of cardiovascular events with semaglutide 2.4 milligrams once weekly injections. This benefit occurred early and was concordant across all subgroups. There was no unexpected safety findings or serious adverse events. Semaglutide 2.4 milligrams is the first weight management therapy proven in a rigorous randomized controlled trial to reduce the risk of cardiovascular events, establishing overweight or obesity as a modifiable risk factor for cardiovascular disease.